studios in New York City. This is Charlie Rose.
One of the great challenges of the 21st century is to improve global health. Life expectancy is 78 years in the United States, but the average newborn will not make it to 40 in some of the world's poorest countries. There are many reasons for this disparity. Infectious diseases kill millions of people throughout the third world each year. Malaria claims up to 3 million lives every year and infects up to 650 million people. HIV/AIDS also kills 3 million every year, and 90% of these cases are in developing countries. Neglected tropical diseases like hookworm and yellow fever also cause an enormous burden that only the poorest have to bear. Many of the leading killers have been contained in first world countries and are easily treatable. The problem of global health is not only a matter of disease and medicine. Issues of poverty, infrastructure, and the environment are all inseparable. Fortunately, more funding than ever is being devoted to this fight. Some progress has been made. Vaccines and other technologies are being developed that could one day eliminate the worst diseases. Also, mortality of children under 5 has dipped below 10 million a year for the first time since the statistic has been recorded. But for now, large-scale improvement remains theoretical. Joining me now are 4 experts in the field of global health. Jeffrey Sachs is director of the Earth Institute at Columbia University. Until 2006, he was director of the United Nations Millennium Project. Tonya Villafana is the director of the Portfolio Management System at the Malaria Vaccine Initiative. Her organization recently announced a successful trial vaccine for malaria. And Veneman is executive director of UNICEF. Peter Hotez is the president of the Sabin Vaccine Institute. He is an expert on neglected tropical diseases. And once again, my co-host is Sir Paul Nurse. He is a 2001 Nobel laureate in physiology or medicine and the president of Rockefeller University. I am pleased to have all of them here for this conversation. Let me just start with this issue. I mean, what is the state today of global health, and how do we measure it?
You know, Charlie, this is a very interesting problem because it's so multifaceted. It's, of course, a medical problem. We have these major diseases you just listed, malaria, TB, AIDS, for example. We have some idea of how we may treat them, but we know that there's new ways we can develop. So it's part of this is a scientific problem, part of it's a medical problem. But part of it is also a straightforward health economic problem and how we apply that in the developing world, because it is different, quite different circumstances to how it is in the United States. And I don't think we always fully understand the sort of drivers that we have to appreciate if we're going to sort out this problem. And then there's a third issue, which is all to do with, even if we actually solved the scientific, the medical problems, if we worked out the economics, how do we actually deliver that on the ground? I mean, with the infrastructures often in very weakened conditions. So I think we have to think about this in with a range of issues, not simply a scientific one, not simply an economic one, not simply a developing one on the ground. I'd like to get a sense of that overall picture. I wonder if Jeffrey could kick us off with just putting it all in perspective for us.
Well, thanks, Paul. I thought both summaries were perfect, that we're making a lot of progress, but there is an amazing amount of disease and death that still occurs every year that just could be controlled massively if we put our attention to it. So the good news is, as you said, Charlie, that the number of children under the age of 5 who are dying every year of infection has dipped below 10 million. That's good news because in 1990 it was about 13 million deaths, and it's come down even though the numbers of children have gone up because of population growth. So that sounds good, but on the other hand, all of a sudden you think 10 million children dying of things like malaria or measles or other infections, diarrheal disease or respiratory infection that can be controlled by an antibiotic or a vaccine or something as simple as a bed net or a dose of anti-malaria medicine. So the wonderful thing is we have these powerful technologies, and we see in many parts of the world that these diseases have gotten completely under control. And at the same time, we have nearly 10 million deaths per year of young children from what should be completely controllable causes. And what Paul says is really the point. The deaths are occurring in places of extreme poverty. So we have to face the basic question, how do you have our powerful techniques like vaccines or medicines or bed nets reach the poorest of the poor because they can't afford them on their own? Their governments are also impoverished because they try to collect taxes from people who have no money. And so the question is, can the rich world and the poor world work together to solve this problem? Now, we've promised many times to do that. 30 years ago, we said there would be health for all by the year 2000. Well, we kind of missed that one. Then in the year 2000, we said that by the year 2015, the child mortality should be cut by 2/3, and the maternal mortality, let's not forget the mothers dying in childbirth because there's no obstetrician around for an emergency. 500,000 mothers dying in the poorest countries, that maternal mortality should be cut by 3/4. Those are the Millennium Goals. So the question is, can we meet those goals? My answer would be yes, and Veneman, head of UNICEF, can tell you there are the ways to meet them, but the other question is, even if we can, will we get organized to do it?
Can we? Will we?
Well, I think that's the question we have to ask. And I think that when you see the progress that's being made, I continue to believe that with a collective sense of urgency, we can meet or nearly meet these goals. As we've talked about the under 5 mortality rate, which is one of the biggest measures of child illnesses and so forth. But it's important to recognize that that rate has dropped 60% since 1960. So we know that progress can be made. We've seen measles mortality be reduced from 1999 to 2005. They set a goal, reduce measles mortality by 50%. That was exceeded. Globally, it was reduced 60%. In Africa, 75% reduction in that 6-year period. Coverage of bed nets, it has increased from about 30 million nets to 63 million nets in just a matter of a couple of years. We've seen increases in breastfeeding, which we know is very important for children's health and survival. We've seen increases in clean water available, which is also the diarrheal diseases from dirty water are very impacting on children in the developing world. But I think one of the things that's setting us backwards on some of these figures, and the figures that you pointed out early on the life expectancy, is in southern Africa with HIV and AIDS, and that's really having a serious impact in reducing reducing life expectancy from the 60s into the mid-30s in some countries.
What astonishes me is how inexpensive so many of these measures are, and yet this is probably the most cost-effective way to lift people out of poverty. If nothing else, Jeff Sachs has taught me that these conditions not only occur in the setting of poverty, but they promote poverty. These are the reasons why poor people stay poor. For instance, hookworm infection, a disease of 600 million people. 1 in 3 of the world's poorest people who live on less than $2 a day have hookworm. Excellent economic analyses showing that chronic hookworm infection in childhood will reduce your future wage earning capacity by 40%. Lymphatic filariasis, a disease of 120 million people, causes $1.5 billion in economic losses for India alone. And we don't even know how much it is for sub-Saharan Africa. These are easily preventable, easily treatable for pennies a person per year. Incredibly astonishing.
But is it a question of money, primarily? Jeffrey, you're shaking your head.
As weird as it is, take a case, and you know that I'm nearly obsessed with this issue, malaria bed nets. Every few months, you let me rant and rave about getting malaria bed nets out to the world. $5 for a bed net which lasts 5 years, but poor people can't afford them. And when you charge even $1 for them, you basically prevent the poorest half of the rural population in Africa from having a chance because they have no money. So it's hard for us to imagine that a little bit actually prevents saving lives. But it's amazing. Last fall, in Kenya, just as an example, because we now have some great results from this, they gave out 2 million bed nets for free in some of the poorest districts with the heaviest malaria burden. And now, published in a British medical journal, Lancet, just a few weeks ago, they showed in those districts that the deaths went down 44% of children under 5 by this very simple 2-day intervention of just handing out bed nets to people that need them. So money is critical, as weird as it is. Even when it's just pennies for the medicine, that's too much for people who have nothing. But for us, it would hardly be noticed. And a point that I find shocking, there are 300 million sleeping sites in Africa where you need to put a bed net over, and these nets cost $5 each. So it's $1.5 billion needed for that. Can't be afforded locally. But that's less than we spend for 1 day on the Pentagon. So 1 day's Pentagon spending would cover every African sleeping site for 5 years. That's the kind of great opportunity we have, which would save millions of lives if we choose to make that choice.
This is your disease.
Well, malaria, yes. I mean, I want to point out one thing. I do agree money is a big part of the problem, but I also think it's about creative partnerships and innovative thinking. We have an arsenal of new interventions that can also join in helping to make this happen and make the kinds of changes everyone on the panel is talking about. Well, we're developing vaccines. We're seeing greater successes with new technologies than ever before. As you mentioned previously, the Path Malaria Vaccine Initiative in collaboration with GlaxoSmithKline and an African clinical trial site in Mozambique has shown that we may have a vaccine that will move into phase 3 efficacy trials, which is the latest stage of clinical development testing, as early as next year. This is the furthest we've ever been along. I think I agree with everyone that it's money, but I also think it's about thinking out of the box and being innovative in terms of how we use that money to get done what we need to get done.
I want to ask Anne something, actually, because you gave us some pretty impressive statistics. What do you say we've learnt from those improvements that would help us in the future? I mean, what lessons did you learn from those improved situations?
Well, I think it, number one, shows that if you invest in health, you can get results. And I think that's really something we have to recognize. I also think as we talk about all of these different diseases and interventions, whether it's deworming or vitamin A or bed nets or measles vaccines or other vaccines, we have to look at them as integrated packages that are given out at the community level so that you don't just hand out bed nets, but you give them when the child is vaccinated or when the mother comes in for prenatal care. Because we find that you can make more sustainable systems if, in fact, you build these community-based integrated approaches. One of the things we saw from the 80s to the 90s is that vaccine rates got up very high for basic childhood vaccines. And yet, that began to fall because it was all done in a campaign mode. Now we're recognizing as a global community that you really have to build basic sustainable community integrated systems for mothers and children. And keep in mind that it's very important to begin that care with the pregnant mother, because a healthy mother is more likely to deliver a healthy baby.
Okay. Jeffrey.
I was just going to say, Paul, also, another way to summarize that is you need a tool like a vaccine, you need the financing so that it can reach the poor, and you need a delivery mechanism as part of a health system. And if you have those three things, absolutely amazing things can be done. And we keep finding one after another, okay, get the measles under control, boom, in 5 years, amazing results. Get bed nets out, 2 days, 2 million nets, and now we've had another 30 million nets in the last couple of years, and it could go up to 100 million a year to cover all of those sleeping sites. Get mass chemotherapy, so-called, giving every child a pill to deworm. Not only will they learn better, but you can get all the community routinely covered. So there's a lot of cleverness right now of actually how to deliver as well. UNICEF and the International Red Cross have done brilliantly on combining the measles vaccines with the bed net distribution. And Peter's group has done brilliantly on showing how to get this package of medicines out for the deworming. And so a lot of clever things, little bit of financing by our standards, because just to come back to the 250 you need, 250 million. Rounding error, there are 1 billion people in the rich world, so that's 25 cents per each of us over a year. And then you can deworm more than 500 million children. It's incredible what can be done.
Someone once said to me, talking about a national problem, and I'm asking this in terms of an international global scope, that we need here a czar. Do we need a czar of global health so that there is a kind of clearinghouse, there is some centralization of focus?
Well, one of the problems is it's very important to realize that these diseases don't occur in isolation. The same child that gets malaria is also getting hookworm, is also getting schistosomiasis, is also getting respiratory infections, so that we need better mechanisms to integrate all of these different interventions. We need to deliver packages of interventions, not simply single measures. So, for instance, it turns out that when you use the community drug distributors that give ivermectin for river blindness of parasitic diseases, if you use those same drug distributors, if they drag a bed net with them, the use of bed nets goes up 9-fold. So right now, so many of our health interventions are siloed. The AIDS people don't talk to the malaria people don't talk to the wormy people. We need to bring them all together in a unified mechanism, and it will change the world.
Would a czar do that? Yeah, sorry, how would you think a czar could work to do that?
Jeffrey, you were nodding your head.
I'm not sure about that.
Well,
I was going to say one interesting thing about public health in history is often, actually, it's been a general in charge. Yeah. And quite interesting, of course, was General Gorgas, who cleared the mosquitoes from the Panama Canal zone. And when the world eradicated smallpox, that was also an operation. Every site this had to really be a very rigorous approach. When UNICEF took on the immunizations, Bill Grant drove that in the 80s.
So you're in favor
90s.
Of this idea?
Well, I think that if we take our targets and we view them as goals, and their goals as partnership with poor people in poor countries, and we have leadership on this, we'll get the job done. And with all the good ideas around and all the things that UNICEF has proved, yes, we need strong leadership and a strong commitment. We will meet that goal. Kind of the moonshot analogy, and it really makes sense.
You have reservations on what ground?
Well, no, I mean, I guess I had a reservation on calling it a czar, but I agree with Jeff. It's a shared vision, a shared strategy, working in partnership with our counterparts in the developing world. It's so.
Boy, do they want it
absolutely.
too.
Okay, but do you need some, for the lack of a better word, centrality of leadership?
I think you need a shared vision by leadership.
Okay. Let me come to this question for you and then flip it open. It is, I hear two things here. One is that you're doing fascinating scientific research in terms of vaccines. We all know about that and other areas. On the other hand, there's this basic dilemma of implementing, executing, delivering what we already have. Is this a great debate within the global health initiative community?
Well, I think it is. I mean, we have experts here, certainly more than me. I get a sense that in the short term, we're talking about implementation. There are things we already know. We've heard about the nets. There are cheap treatments already available. Then there is the science. I mean, the stuff I'm particularly interested in, because we have particular challenges here of how we can develop treatments that can be delivered in these less than ideal circumstances. And I think that is research that we really should be thinking about, because often in the developed world we can imagine more sophisticated treatments, we can do that, we can ensure compliance and all the things that go with it. But what we've got to sort out is ways of actually delivering treatments that are very simple and straightforward, a single dose a year or something like that. And that, I think, does require good science and good vaccine science in particular,
It's not an either-or argument. It's not science versus implementation. I'll give you an example. In India, in the 1950s, we had 75 million cases of malaria in India. By 1961, we had reduced it 3 logs full to 75,000 cases. Why? Because of widespread use of chloroquine and widespread use of DDT, and the insecticide DDT. By 1962, the number of cases was 100,000. Then it was 200,000. Then it was 400,000. So by 1960, the WHO was predicting the global eradication of malaria, in part because of their experience in India. But why? Because of DDT resistance and chloroquine resistance. It completely derailed those efforts. Had there been parallel ongoing research going on at the same time to develop a new generation of control tools, maybe we would have solved the problem. And the same thing is true today. We have to give antiretrovirals. We have a moral obligation to maximize use of anti-malarials and bed nets, deworming drugs. Don't stop there. Develop the next generation.
We tend to
control
declare
tools.
victory too early is the problem.
Always you have to run with what you have and with what you're going to need for the next generation, no question.
Absolutely, and we have to think, I think if we develop a vaccine and we can't get it to the people who need it the most, then we would have failed in our mission in terms of getting a solution to malaria. So I absolutely agree that while we're thinking about the science, coming up with innovative ways to develop a vaccine, looking at different platforms and technologies to do that, we need to think about how we deliver it in these settings. That being said, I think places can rise to the challenge, and we've seen that with antiretroviral drugs. In Africa, we've seen compliance when everybody thought that people wouldn't be able to comply with regimens. And I think, it's a question that remains to answer. We've got to do the research, we've got to look at it, but people can also step up to the plate and do what needs to get done.
I think that part of the problem has been that the research has sometimes been done in isolation, and it's also not been done for the developing world. That's changing. People are investing large amounts of money in looking at ways we address diseases that are not common to this country, in particular malaria vaccines, and so forth.
And especially Bill Gates is making.
And especially the Gates Foundation, exactly. I just recently spoke to their Grand Challenges for Global Health meeting, which is all their scientists. And I think one of the things that came out in that meeting is that you need the combination of discovery tied with development and tied with delivery, so that you're looking at so that those people that work on the ground in the developing world are working with those who are trying to develop the new and discover and develop. And you need the combination of all of this if you're going to continue to make the next generation of interventions that will really make a difference in global health over the long term. And the other thing that I think we have to look at is looking at the integrated package that is beyond health. An educated person is more likely to be a healthy person, so education is very important. Clean water is critical to global health. And all of the kinds of things that we work in development really all come back to having an impact on global health.
Well, I mean, I think we may have said it in other ways, but I mean, it's so obvious to me for a long time that poverty and health are so intricately linked. And there's no way you can separate them.
That's right. One causes the other. The other causes poverty causes disease. Disease causes poverty. You get in a vicious circle. You have to help break the vicious circle.
Put the environment.
And it's education too, because kids don't learn when they have worms in their bellies, and they can't be educated if they're infected with malaria.
Put the environment in that whole sort of mix as well, in that context. How does that impact?
Well, one thing is, as the Nobel Peace Prize this year taught us, we've got looming over a lot of some grave long-term challenges. That's the climate change. And we know that diseases like hookworm and malaria are climate determined, and actually the warming is already leading to a spread of the area infected by these diseases. So that big issue, which we're also grappling with on the side, is, like everything else in this world, connected to this as well. You can't just argue do this or do this. They're all interconnected. It's also the case that the local environment that poor people live in is a dangerous environment, and that being poor means you don't have a pump for safe drinking water. It means you don't have a housing structure that protects you from the insects that transmit the diseases inside the home, and so forth. It means that, shockingly, 1 to 2 million children die each year of respiratory infections that are probably aggravated significantly, if not caused by the indoor air pollution of cooking on a wood stove, cooking wood on a 3-stone stove. And so the physical environment of the poor is just not safe. And it goes to Ann's point that there's a broader issue of, more generally, the escape from poverty, of which direct attacks on disease is part of it, but so too is ensuring that children are in school and so on. Now, people that have thought a lot about this, including the world leaders, decided on these Millennium Goals in the year 2000 to say we have to approach poverty in this interconnected way. And the Millennium Goals themselves, there are 7 main goals, the 8th one being that we're going to partner with the poor and the rich, but the 7 goals are about hunger, they're about schooling, they're about gender equality between girls and boys, men and women, they're about maternal and child survival, they're about the control of diseases, they're about access to safe drinking water. So they take a holistic approach. They say, yes, we need to approach the challenge of extreme poverty with a whole vision that understands that it is education and disease control and more food production and livelihoods to earn income. It's a very clever thing. It is recognizing there's no one single magic bullet to get this done, but on the other hand, it's also not so overwhelmingly complicated that it's just a morass. It's a few very important things that need to be done.
No, I want to come back to that. We mentioned neglected disease. I mentioned in my introduction. What are we talking about? I mean, what are the 3 or 4 that are most neglected?
Well, it's a great question. So if you look at going back to the Millennium Development Goals, the Millennium Development Goal 6 says to combat HIV/AIDS, malaria, and other diseases. And unfortunately, we've kind of forgotten about the other diseases a little bit. What we're talking about are a group of primarily worm infections. These are diseases such as hookworm infection, river blindness, elephantiasis. These are the most common infectious diseases of the world's poorest people. So of the 2.5 billion people who live on less than $2 a day, roughly half have 1 or more of these worm infections. So that when you go into a developing country in Sudan, so let's say, or go into sub-Saharan Africa, anywhere, what you'll see is that all of the kids in the village are chronically infected with these worms. These are chronic infections, these are debilitating infections, and very sadly, they're also very disfiguring. And because of disfiguring, such as elephantiasis, where you have someone's genitals or limbs grossly distorted because of the presence of these worms, they have an enormous stigma attached to them. So the stigma particularly hits women of reproductive age very hard. They're either unable to marry or they're not allowed to hold their children, even though this has nothing to do with the transmission of the infections. The problem with these worm infections is they don't kill. They kill some, but they're mostly debilitating and chronic infections, and so it's very hard to give a 2-minute elevator speech about these worm infections.
Problem in quotation marks, just to explain, you mean in terms of helping to motivate people to...
Helping to motivate people to understand why they're these important.
Yeah.
And if I could just say one other thing, and the other very important part about these worm infections is that it promotes susceptibility to malaria. They exacerbate the disease caused by malaria, and now there's evidence that they increase transmission of HIV/AIDS. So these are your stealth, because they're so easy to treat, 50 cents a person per year. This is your stealth weapon for AIDS. This is your stealth weapon for malaria.
But the biggest killers of children are?
Well, first, about 37% is neonatal causes, so those who die in their first month of life from, a variety of reasons. Then pneumonia is the number 1 after that. Treatable with a basic antibiotic. Malaria, diarrheal diseases, these are all the big killers of children. And vaccine-preventable diseases, for the most part.
There was a flurry of news last week about microbes and the amount of death that exceeded that from HIV. Please tell me what that was all about.
Oh, well, I didn't read this particular article, but what is clear is that microbial diseases, which 30 years ago we thought we'd beaten, I mean, eliminated, it was just going down and going to disappear, have just come back. I mean, this is associated with antibiotic resistance and the like. It's, of course, a problem in the developed world with these superbugs, which are resistant in hospitals. But we see it on the ground. I mean, the antibiotics that we'd have used as first line of defense are gradually becoming a problem because we need to have new antibiotics. That's why I said a bit earlier, we declare victory too soon. These come back and they bite again. They are evolving. They are changing. These bugs are changing. So this is a major problem that we thought we'd solved in 1960, and we have not. And then we have an issue of how we actually do solve them, because when we have a research system in industry which is driven by how much profit one can make, if the company cannot make profit by producing new antibiotics that would work in the developing world, those new antibiotics are not going to be developed, they're not going to be made. And I'm very interested in this problem. I'd like to hear what our visitors here would say about that, because the normal drivers are not actually operative here. I mean, how do we deal with this? I mean, obviously Gates putting money in would be one way of dealing with it, but basically the system we have, which we have got used to operating with, is not going to deliver the solutions to the sort of problems that you identified, Charlie, with microbes, and also these specific diseases. What do we do about this?
Well, I think you've hit the nail on the head. How do you incentivize an organization to make a product for people who can't afford to pay for it? This is the biomedical equivalent of the movie The Producers. Instead of Springtime for Hitler, we're making Springtime for Hookworm. How do we develop the next generation of products for people who can never afford to pay for it? I'll give you the urgency of this. 20 years after the licensure of hepatitis B vaccine, we still haven't penetrated markets in developing countries. Look at the HPV vaccine, the vaccine for cervical cancer. It's estimated that 38,000 women in South America die every year of cervical cancer. Most of those 38,000 women in South America are women who are younger than who die in the United States because they don't have access to routine pap smear screening. So what you're looking at are 38,000 women in their 30s and 40s who are dying every year from cervical cancer, 38,000 families totally devastated and destroyed. Multiply that times 20 years, because right now, HPV vaccine, the cervical cancer vaccine, I just got my daughter vaccinated. It's $360 for the three vaccinations. There's no way you're going to get a $360 vaccine administered to poor women in Latin America. So we need to find new innovative mechanisms to bring the price down and to have a structure, an infrastructure by which you can make vaccines for less than $1 a dose from day one. That's what Tonya's doing. That's what we're trying to do at the Sabin Vaccine Institute.
And I think that's really interesting, because even some of the examples you've used are things that have markets. HPV has rich world markets that you could tap into. A malaria vaccine will not, have a rich world market necessarily. A traveler's market's not enough. One thing we could talk about, and I'm by no means an expert in this, is new ways of creating innovative financing mechanisms and pull funding. One thing we've been talking a lot about is advanced market commitments. And we're going through a pilot case of this now for a pneumococcal vaccine. And I think that's a really interesting thing for us to look at going forward in other countries.
About that, because we actually had a meeting about that many years ago when we proposed that. There are basically two things that need to be done when you're trying to develop a medicine or a vaccine or a diagnostic for poor people. Now, if it's for a condition that rich people also suffer from, then it's likely that the rich world market will give the incentives, and then the problem comes, how do you get that same medicine that's been developed to the poor, what we've been discussing so far. But what if it's a condition like these worm infections or malaria and so forth, which is basically a poor region problem? Then the markets by themselves won't do it. And there are two kinds of solutions that have proven to be effective. One is you put money on the table and you basically give an incentive to get the research done, and that's what Bill Gates and Melinda have been doing. And they've set up a number of quite remarkable efforts for malaria vaccine, for tuberculosis vaccine, for AIDS vaccines, for new medicines for each of these. And that's putting money on the table and getting the big companies to partner, but because they were getting paid to do this. And then they make the deal, if you get something, it won't be under a patent-protected high price. We'll make that available on an open license to the poor. That's one way. The other way, which is a way that a colleague, Michael Kramer, and I promoted starting about 10 years ago and is now being tried for the first time, is something that Tonya mentioned called an advanced market commitment. The idea is try to make it as if there were a market. So get a bunch of governments together and say, whoever invents a vaccine for so-and-so will be the market for you, and we'll announce today, though there is no vaccine, that whenever you have it, we'll pay $10 a dose from you. Now, go take that to the bank. Go get a venture capitalist. Go get some rich investors to do it, because there's a guaranteed market for you. So that's what's called an advanced market commitment. And this is just now being tried for the first time with the pneumococcal. But it could apply to malaria vaccine, it could apply to a hookworm vaccine, it could apply to these other conditions where you don't have a real market because the people that you're trying to help are too poor to be a market.
I mean, one question I have about the advanced market commitments is whether that will work for products for diseases for which there's absolutely no U.S. or European market. It'll work, I believe it'll work for pneumococcal vaccine, it'll work maybe even for malaria. I don't know about hookworm. I still think for hookworm, or diseases like hookworm that only occur among poor people in developing countries, we still depend heavily on organizations like the Bill and Melinda Gates Foundation to step up and really do the right thing and fund it. The problem being, Bill Gates can't be everything to everyone. And so the problem is we need more organizations like the Gates Foundation to
But let me just raise this point on that. My impression is that global health and global poverty has become a much more hot, for the lack of a better word, issue. And therefore, it's attracting more philanthropic dollars. People who might have formerly given to a very worthy cause, let's say a museum or a library, are now somehow attracted to river blindness or things like that. And therefore that leads me to, A, is that true? And so therefore there are more dollars and more interest in global health issues. It also leads me to sort of this, which is always fascinating for me, is there out there among, especially the two of you, silver bullets? I mean, where is the hope for the research side, vaccines, whatever kind of development that we ought to know about?
I may be naive because of my youth, but I believe that we will have a malaria vaccine in my lifetime, and I think we have a promising candidate now, as I mentioned before. Easily.
Because she's so young. Exactly. So close to the solution.
Right, both.
But we do. We have a really exciting, robust portfolio of vaccines that we're looking at developing. We've got a lead candidate that shows some effect against clinical malaria and also against the most severe forms of the disease. And as I mentioned before, that's going to go into phase 3 efficacy trials next year, the latest stage of development, and we'll know in a few years whether or not that will work. That will be a partially efficacious vaccine. It wouldn't protect totally against malaria, and at the same time we're developing new candidates, utilizing new technologies, utilizing new platforms, and I think they're very promising. Another very promising candidate that we have is the Scenaria whole sporozoid candidate vaccine, which is a whole parasite vaccine that's very much classical vaccinology. That's another up-and-coming vaccine.
How does that work? Be more effectively?
Well, the candidate vaccine that we have in current development is actually targeting one part of the life cycle of malaria. It's a recombinant protein approach, so it's a fairly simple, straightforward approach.
That's a protein that's been made by splicing genes together to make a new sort of protein.
Right. And the whole sporozoid approach that we have, that we're collaborating with Scenaria, Steve Hoffman's group to develop, is really, I think, a classical live attenuated approach to developing a vaccine, irradiating the malaria parasite and giving that as the vaccine.
It turns out that the best proof of concept for vaccines is taking the whole organism and somehow making it weaker. So the oral polio vaccine is taking attenuated strains of polio vaccine, same with measles vaccine. The problem for the vaccines that Tonya and I are focused on is we're dealing with whole animals. We're dealing with more complicated organisms, and so it's much more complicated to attenuate them. So in some ways, the low-hanging fruit has been done, the easy vaccines. We're not taking on the harder vaccines, but it's still doable. It may take a little longer, but there's no question that we will have malaria vaccines, we will have tuberculosis vaccines, we'll have hookworm vaccines, God willing, and I also believe that an AIDS vaccine is still definitely feasible, although we have had a big setback in the last few months.
What's that?
Well, the setback is Merck had a very exciting candidate vaccine that everyone was always saying the problem is we're not we're too focused on initiating T cell antibody responses rather than the right kind of T cell responses. Merck has made this vaccine. It generated the right kind of T cell vaccine responses, but it's still not protecting. So
it's different parts of the immune system. You have antibodies. There's two parts to it, really. Antibodies, which are proteins that fight disease, and then cells of the body, the T cells that fight. And this was supposed to stimulate the T cell approach, which hadn't been tried before, but unfortunately, or not effectively before.
Well, we're stimulating the T cells, but we're still not getting protection.
We're still not getting protection.
But what I really hope is Merck doesn't walk away from the problem. I hope Merck continues to chip away at it because it's still a solvable problem, I believe.
UNICEF. Tell me about how this fits in terms of your mandate.
Well, we're the largest procuring agency of vaccines in the world. A lot of it is procurement, medical supplies, vaccines, and also working with developing countries on integrated approaches. And we also procure a lot of bed nets. We're one of the largest procurement agencies for bed nets. So all of the kinds of interventions we've been talking about, UNICEF works in these areas, both on the supply and procurement side as well as on the delivery side.
When I had Bill and Melinda Gates here, they talked about antiretrovirals. Where are we on that issue?
The world has committed, the rich world has committed, our governments have said that by the year 2010, just 3 years off, that everybody that clinically needs those medicines should have them available. There should be universal access to antiretroviral medicines. Now, 6 years ago, there wasn't one single person in a poor country that had support from any rich country program to be on antiretrovirals. Many people said it would be impossible to do this at all because the poor wouldn't be able to adhere to the drug regimens or there was no infrastructure. In the last few years, because of the global fund to fight AIDS, tuberculosis, and malaria, and because of the U.S. program, emergency program to fight AIDS, the so-called PEPFAR program, now there is a breakthrough where there are about 1 million Africans right now that are on antiretroviral medicine, and the numbers are going up because the basic process of helping people to get these drugs is taking hold. But we have a long way to go to reach that goal of universal access for all who need it. It's like all the things we've been talking about, though, Charlie. There's nothing which would stop it from happening if we have a commitment, leadership. Maybe it's that czar we discussed earlier, but a plan that says we're really going to meet the goals that we've made. We can achieve what we have set out to do. And it would mean millions of people's lives saved, and it would mean even more millions of children who would not be orphaned by this horrible disease.
I, by the way, am in favor of the idea, notwithstanding, simply because it focuses everything.
Absolutely, it does.
But I think this point about, it's only been in about the last 3 or 4 years that the whole AIDS issue has been addressed with both the drugs and the testing. And you can really see the difference on the ground in Africa. I just got back from Botswana. Now, Botswana happens to be one of the most proactive countries in dealing with the HIV problem, but they've also got a very high prevalence rate of about 35%. But they now have coverage of what's called PMTCT, which is prevention of mother-to-child transmission. That means testing pregnant women and making sure they get the right kind of drugs before they deliver so that you have less chance of passing that on. They have 93% coverage. Now, the average of it was about 10% 3 years ago. They now have reduced, because of that, they've reduced mother-to-child transmission of the disease from 40% to 5%. So this is what this money that's been put in the Global Fund, PEPFAR, is really making a difference in some of these countries. But the situation in southern Africa, particularly, South Africa, Botswana, Swaziland, Lesotho, Zambia, these are countries that have very high prevalence, and it's going to take a lot to turn around the AIDS pandemic. And
Charlie, the whole history of this is that on this also, every single thing that's been tried before it was tried it was claimed that it would be impossible. Every time we've gone ahead and done something, it's turned out to go much better than was predicted.
What's the best example of that?
Well, whether it's getting antiretrovirals out, or whether it's getting the bed nets out, or whether it's getting the vaccine coverage. And when the smallpox eradication effort was first proposed, most people said, no way, no chance. Actually, the United States government wasn't even in favor of it. It turned out it took a lot of pulling and pressure to get that done, and then it worked. And it was a vote of just 2 votes at the World Health Assembly, so-called, which said, okay, we'll try it. And then it turned out to work in this wondrous way. So the lessons of public health are that these techniques are very powerful and very effective, even in places that are extremely poor. And the problem has been just getting ourselves motivated and organized to do it.
Just back to AIDS briefly, because, I mean, what can we say about certain problems on the ground? I mean, South Africa, I mean, there's this resistance to treatment. In other countries, I think Uganda's done particularly well, for example. Right. Why is there such a variety of approaches here?
Leadership plays a huge role, and here's this very odd phenomenon that President Mbeki of South Africa for a long time was in denial. And his health minister, even worse, peddling garlic rather than antiretrovirals as a solution. So it was absolutely unaccountable how badly it was handled by that government. Contrary-wise, in Uganda, just like you said, President Museveni sounded the alarm and said everybody has to know, and got some tremendous things going. So leadership played a huge role. In Botswana, which was so hard hit because of its large migrant population and mining population, the former President Mohai and current president have been completely dedicated to this. So you need that kind of leadership. But the notable thing in Africa right now is how many places there are with good, strong leadership that are saying, we'll take this on, give us a hand and help us do it, but we will take this on.
Something that we can't ignore in the solution for global health problems is the importance of the multinational drug companies. At least in my field, I can tell you that the drug companies are actually the good guys in this. It's the reason we can give that rapid impact package of deworming drugs for 50 cents a person per year is because Pfizer is donating the Zithromax, Merck is donating the Mectizan, Johnson & Johnson is donating the mebendazole, GSK is donating the albendazole. We don't have all of the drugs donated, but it's making a huge difference. So we don't have to even worry about the cost of the drugs, it's the delivery. If we can take that model of the drug companies really stepping up to the plate and helping with these neglected tropical diseases, these deworming drugs for other diseases as well, that's going to take us a long way.
Is there something beyond the horizon? Again, this is my journalistic obsession, that we don't know about. I mean, one thing we haven't factored in here is population as an issue, and how that, when we talked about environment, we talked about the combination of poverty. But is there something else going on out there that we're just beginning to get a little sniffling of?
Yes.
What is it?
Actually, first of all, is there something going on that we don't know about? Surely, is the first answer. First, because of the pressures of humans on the environment all over the world, we're seeing a lot of new diseases. Right. Because people are coming into contact with animal reservoirs of disease that they never did before. Because diseases are being transmitted in new ways, whether it's avian flu or SARS or many others. There's also something else that's lurking, and that's affecting us certainly, but it's affecting also the developing world in a shocking way. And that is the non-infectious diseases, the so-called non-communicable diseases, notably the lifestyle of urban, a little bit couch potato, with fast food reaching the world. And something unbelievable is happening right now, which is that there is an epidemic of adult onset diabetes, even in the very poor places. And this is a big shock. It's not infection, it's the way people are eating, what happens to sedentary lifestyles. So there's no end to the problems exactly, but there are huge gains that can be made. But you do get the idea. You cross one mountain pass, we'll see other challenges ahead, no question about it. But let's take on these millions of lives that can be saved now, because it's right in front of us, something that can be accomplished now.
I think one of the things we haven't talked about this evening in the discussion of global health is the importance of nutrition. About 50% of the child deaths under 5, a contributing cause is lack of nutrition or malnutrition. So that if you have malaria and you're undernourished, you're more likely to die. And I think nutrition is a key part of global health. But today we're also not only dealing with the issues of undernutrition, and there's some very exciting new kinds of products in development, like ready-to-use therapeutic foods that are having a dramatic impact. But also there is this issue of overnutrition, and it is hitting the developing world in quite a big way.
Some places, yeah, in the urban centers.
Yeah.
And in the richer countries, for example, in Botswana, I spent many years on the ground in Botswana, and HIV/AIDS is a problem, but we started to see chronic disease affecting people as well. As soon as those people who made it through the 30s and 40s start having a whole different milieu of disease.
Somebody watching and listening to this for an hour should take away what?
Well, I'm curiously optimistic, given the size of this problem. I mean, what I think I've heard this evening is, I think firstly, this problem is being taken seriously. It's being talked about seriously, and I don't think it was, perhaps even 10 years ago, and certainly for a decade or two before that. Secondly, I'm hearing there's real resources out there. Interestingly, I think these philanthropic sources are extraordinary, and I get that everywhere. In my university at Rockefeller, donors want to give to this, and of course we have the wonderful Gates Foundation. So there are resources, and I think countries, developed countries, governments are thinking about this too. The third thing I've heard is that some of the solutions seem to be pretty simple, and we just have to get on and actually do it. It's a question of organisation, implementation, and leadership. That really seems to be the key factor, leadership. And the final thing is that there is some science to be done, and we've heard a bit about that, but it sounds doable. I'm coming out pretty optimistic.
Thank you. Optimism is a word I'd like to end on here, if I may. My thanks to Peter Hotez, president of the Sabin Vaccine Institute, Tonya Villafana, the Malaria Vaccine Initiative, and Veneman, the executive director of UNICEF, and Jeffrey Sachs, director of the Earth Institute at Columbia, and Sir Paul Nurse, my colleague on all of these scientific inquiries. I thank you, my friend. I thank all of you for joining us, and we thank you for sharing this time with us, and we'll see you next time.